specialist. I also specialise in the removal of impacted earwax, foreign bodies, infected discharge and debris from the ear canals of patients. We have a client here who attended with bilateral, fully occluding earwax. As per the thumbnail, you would have seen the pre and post images. So this is the pre-procedure image of the patient's left ear. See, the wax is very glutinous, so it's very sticky, like a gluey type substance. So I've just gone in with the Zollner suction probe. We're just at the entrance of the ear canal, and we know that because of all the cilia, all the hairs. The hair follicles in the ear are in the outer third of the ear canal. The outer third of the ear canal is where all the sebaceous glands, ceremunous glands that secrete wax are, all the hair follicles, and it's made up of cartilage. And there's a thick layer of skin that's 1 millimeter thick and some fatty tissue. So with glutinous type of wax, suction is not always the most appropriate because it blocks the tube. So I'm just using a forceps, not forceps, Jobson horn. There was a gap superiorly at the roof of the ear canal. So I've managed to insert the Jobson horn into the gap and slowly but surely extracting the earwax. You can see how dense there is. You can, if you look just at the top, the roof, there is a little view of the eardrum in the distance, so it's not fully occluding. And you can probably tell by the consistency, it's very dense, very thick, very glue-like. So we can see the top part of the eardrum there. The problem with the Jobson horn sometimes when you're trying to extract wax like this is when you get in and behind the wax and bring the Jobson horn forwards, you're almost inadvertently compressing some of this soft wax at the base of the ear canal. So although you're removing the blockage, you are coating a thick layer of wax at the bottom, which is then a bit difficult to remove because you're having to make contact and scrape the ear canal. So that was what was happening in this case. I've just tried to go back in with the Zollner suction probe, trying to lift this thick layer of wax from the base of the ear canal. Wasn't really making any progress. So I've just installed some olive oil drops, and what I'm doing now, I'm just hopefully with the olive oil, it will lubricate this wax off the base of the ear canal, and then just using the Zollner suction probe just to elevate and loosen the wax and the keratin. You can see some keratin there on the right hand side. That's the glossy white creamy substance, and you'll see me just tugging this away, lifting it off the posterior canal wall near the entrance, and it will get a bit blurry in a moment because the ear is still a bit oily, and with the cilia they're also coated with the oil, and when you put the endoscope into the ear canal through the cilia, it does kind of sometimes fog up the screen. But I'll just let you watch this part. You can just see how adhered this keratin is to the posterior canal wall, and as I said, it was slightly blurry, but I can still see exactly what I'm doing. I'm just loosening this plug of wax, bringing it forwards, and that's the benefits of using olive oil drops for this type of wax: glutinous, sticky, wet, thick, clay or mud type of wax. Just mopping up near the entrance now. You can see it's got a bit of keratin and it's matted against the cilia, the hairs. Just using a fine end gauge. So sometimes with a fine end gauge, it's much better at lifting dead skin and peeling dead skin off the canal wall. It's also a lot quieter. The problem with keratin, if you sometimes use a standard Zollner suction probe, the skin, the keratin gets trapped at the tip and it flaps violently, and when it flaps violently it emits a very high frequency squeal which is almost deafening, not only for the patient but for the clinical ear care specialist. So that's a post image of the left ear. You can see the tympanic membrane's intact, a bit of tympanosclerosis, a bit of scarring there, but it's generally healthy. So this is the pre-image of the right ear. The wax again is glutinous, but I would say it's a bit softer and wetter, so suction was actually a lot easier in this ear. So we're just working at the base, and this is the glutinous part of the debris, but a bit further in it's a bit wetter. We can get a better suction grip. You can see I'm just loosening this wax at the top of the ear canal, the roof. You can see all the keratin that's attached to it. And I'm just going round to the posterior part of the ear canal now. So I've loosened the northern hemisphere, if you like, of the wax and dead skin plug. Just remove that. And the best way to loosen wax and keratin off the canal wall is to get a suction grip and then almost wriggle it out of the ear. So you make little circular motions. You can see I'm bringing this forwards. So there's no need to instill olive oil drops in this ear. I am a big fan of using olive oil drops during procedures, but only when it's necessary. In this case, yeah, it's a bit of a resistance with the consistency of the wax and the dead skin, but it's still coming out. By the time I put the drops in, soak it for 3 or 4 minutes, drain the ear, it's still a lot quicker removing it using just suction, dry without any drops, and we're almost there now. So it's a little plug of wax and dead keratin. And all that's remaining now, it's not actually wax, it's all keratin. You can tell by the texture, the glossiness. So there's a bit of dead keratin here, which is a bit mushy and it's matted against all the hair. So again, we know we're near the entrance, literally just probably 2 or 3 millimeters into the ear canal. Just lifted this matted debris, dead keratin, and there's a bit of wax attached to the end. There's the tympanic membrane in the distance. So I'm just going to mop up around the edge now. So I've just gone back in with the Zollner suction probe, just getting all this matted debris, dead skin, wax off these hairs. The client wears hearing aids, so I'm trying to remove as much as possible so it doesn't obliterate the sound passage to the eardrum and it doesn't block up his hearing aid as well. He is a regular patient, he attends almost every 6 months. So people who wear hearing aids are sometimes more prone to the build-up of earwax, and that's because wax generally in most people, so probably 90–95% of people, naturally migrates out of the ear on its own accord. But if you wear a hearing aid, you're blocking the entrance of the ear canal and almost pushing the wax further in. So just mopping up around the edge. He also has got a bit of otitis externa, a bit of eczema of the ear, so we've just recommended some ear calm acetic acid spray over the counter. And there's the tympanic membrane. So that's a still image, slightly opaque, a bit of tympanosclerosis, a bit of scarring, otherwise nice and healthy. And I've just weighed that wax, so that is 276 milligrams, 0.276 grams. I think the record at the moment is 450 milligrams. I just recently purchased these precision scales. Wish I had it for some of my earlier procedures, because I've not had one since I brought these scales.